Welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. Tonight we're talking about lower GI problems. What would you like to know about the diagnosis and treatment of complaints like hemorrhoids, constipation, colitis, diverticulitis, or colon cancer? Please call in your questions and we'll do our best to address them. Call the numbers on your screen. Locally dial 218-788-2844 or call toll-free 1-877-307-8762. I'm pleased to welcome our panelists. Dr. Robert Erickson, a gastroenterologist with Essentia Health-Duluth Clinic. Dr. Dave Hutchinson, a family physician with St. Luke's Lester River Medical Clinic in Duluth. And Dr. Tom Nelson, a general surgeon with Mercy Hospital in Moose Lake. Our medical students answering phones tonight are Maren Anderson from Lake Park, Minnesota, Daniel Levasseur of Ogema, Minnesota, and Emily Prazik from Grantsburg, Wisconsin. And now on to tonight's program on lower GI problems. Before we start our questions, though, I would like to acknowledge the passing of Dr. Ben Owens. Dr. Owens was a longtime host of this program, but more than that, he was a giant in healthcare in northern Minnesota. Everyone in Hibbing certainly knew Dr. Owens, and we certainly acknowledge his passing. He's going to certainly be missed, and he certainly can't be replaced. Well, let's start out. Dr. Erickson, maybe you could, we're talking about lower GI problems. What is lower GI?
Well, the lower GI, it consists of pretty much you cut it off at the colon and lower. Sometimes people include the small intestine with the lower GI. Upper GI, you generally think of the esophagus and stomach. Mm-hmm. The function of the colon, as we were talking about before, there's two functions of the colon. One is to store the waste until we're ready to eliminate the waste, and the second one is to absorb fluid. Those are the main functions. You can live without your colon. Dr. Nelson will remove patients' colon if they have colitis or other disease of the colon and with an ostomy, but you can't live with your small intestine. Mm-hmm. But it still is a very important organ, and those patients who have dysfunction of the colon know it. And it's like everything else in the GI tract, you take it for granted until something goes awry.
Sure. Thank you. Dr. Hutchinson, you're a family physician. What do people come in, what type of problems do people come in for lower GI problems?
Well, people come in with symptoms. They don't necessarily know if they're related to their lower or upper gastrointestinal tract, but people come in concerned about constipation, diarrhea, abdominal pain, bloating. They may have specific questions about specific diagnoses, risks of colon cancer, concerns about diverticulosis or infected diverticulitis. I feel like one of my main jobs as a family doc, somebody on the front lines, is to identify simple versus complicated symptoms, and especially to make sure we identify warning symptoms. Mm-hmm. Those are important to remind people about. Signs of bleeding, either red blood or black digested blood from the lower GI tract. That's a warning symptom. Fever, pain, especially progressive pain or pain at night. Weight loss. Those are all important warning symptoms to identify.
Thank you. Mm-hmm. Dr. Nelson, now people will come in. They'll notice some bright red blood, say, in the toilet bowl or on their stool, and they'll say, well, it's just my hemorrhoids. Can you talk about that? May not be the hemorrhoids.
Right, that's one of my pet peeves throughout my career, is to emphasize that everybody has hemorrhoids. You're born with hemorrhoids. And so you can't assume that the rectal bleeding or anything else going down there is from your hemorrhoids. So in the case of rectal bleeding, we usually have to investigate the cause of the bleeding and make sure it's nothing more serious before we can assume it's your hemorrhoids. So that's a diagnosis of exclusion, as we say. So depending on your age, we either look with a short scope, but if you're older, we do a longer scope, a colonoscopy, and make sure that there isn't a cancer or inflammatory bowel disease. Other things down there that can cause bleeding that are fairly simple are fissures, fistula, sometimes warts or skin problems. And so it's not always something bad, but it may be something that needs to be treated, and it's not hemorrhoids.
Thank you. Dr. Erickson, we already have a question regarding colonoscopies, and let's just talk about colonoscopies or colon cancer screening. That's a major problem and the problem that should be addressed, and can you discuss that?
Colon cancer screening is a very important part of the healthcare maintenance, similar to breast cancer screening, prostate cancer screening. Dr. Hutchinson, in his clinic, you deal with that many times. So basically, everyone at the age 50 should be screened. If there's a family history, it can be down to age 40 of family history of colon cancer or colon polyps. There are some hereditary types of situations where it's earlier. But if there's a family member who developed colon cancer, colon polyps earlier than age 40, sometimes the screening takes place before age 40. Sure. So I do encourage you to talk to your primary doctor and talk about all the different situations that can occur when the right timing is for colon cancer screening.
And we have a caller from Duluth. One of the first questions is asking about virtual colonoscopies. Why aren't they done if somebody's a little leery about having a regular colonoscopy?
Well, the important thing about colon cancer screening is to have something done. So there's options. There's stool testing. May not be as accurate as colonoscopy, but is an option. Barium enema is still an option where dyes flow through the colon and see if there's polyps there. And virtual colonoscopy, or it's called CT colonography, is a CT scan of the colon. And digitally, they can have a ride through the colon, if you would be, almost a roller coaster ride through the colon as you look on it on the screen. And the issue with barium enemas and CT colonography, if there's a polyp or something found, then you need to go to colonoscopy.
You have to have one done anyway.
So a lot of it depends on the payer. Medicare, still to this date, I don't believe is paying for colon cancer screening for CT colonography. And other insurance companies are looking at that, but it's still an evolution.
Okay, thank you.
I could add a little bit onto that, Dr. Johns, if that's okay.
Sure.
I think it's nice to emphasize really how as we've evolved medically, even over the last 5 years or a decade, how much easier colonoscopy is on people now. I feel that it is. The preps are simpler to do, they're shorter, they're highly effective, and the procedure itself is easy to make people comfortable during. And so it's very safe. There is a minimal risk of significant complications from colonoscopy, but it really has become a fairly easy procedure for endoscopists to perform and easy on patients.
Thank you. Very important point.
Yeah.
Let me ask a follow-up question, Dr. Hutchinson. We have a caller that wants to know about enemas. Are they helpful for constipation? And are there any risks with just using an enema?
To answer the question directly, there are minimal risks to using a rare or episodic or occasional enema. I think the caution any of us would feel when we hear that question is constipation can often just be episodic or related to temporary diet habits or activity habits, but anybody who would think of using an enema regularly for chronic constipation, we really want to make sure we have a chance to make sure there aren't more severe underlying problems causing that constipation. And just treating constipation with recurrent enemas, I would be alarmed about.
Thank you.
Yep.
Dr. Nelson, we have a caller from Duluth wanting to know about what are the treatments for hemorrhoids? If it is a hemorrhoid that's giving you problems, what's done?
Well, what I do in my office is find out what are the symptoms that the patient's experiencing from the hemorrhoids, and then I tailor my treatment according to that. So if they're having prolapse of tissue where the vascular cushions, which are the hemorrhoids, get prolapsed out, then we usually have to do some type of a banding procedure. If they're more advanced and you can't push them back in, then we actually have to take people to the operating room and do an excisional hemorrhoidectomy. But that's very unusual. Usually I can take care of the problems with just plain banding. Now a lot of times people say they have hemorrhoids and they're just floppy skin tags like your earlobe on the outside, and people call them hemorrhoids. Well, you have to figure out what their symptoms are when people come in saying, oh, I got problems with hemorrhoids, because if that's the problem, then treating the hemorrhoids isn't going to do any good. You need to usually just snip off those tags they're causing hygiene problems or just simple irritation.
Is there anything at home you can do? Just, suppositories or creams?
Well,
or?
I usually, being a colorectal surgeon, I usually don't prescribe any type of topical thing because it really isn't beneficial.
Sure.
It's more helping the patient feel like they're doing something.
Sure.
But oftentimes just a good high fiber diet, don't strain at bowel movements, is treatment for a lot of hemorrhoidal problems.
Thank you. Dr. Erickson, a caller wondering about acute diverticulitis, a fairly common condition. Is there anything you can do to help prevent diverticulitis?
That's a good question, and people always thought that, I need to pull out every little seed in my diet and pull out the strawberry seeds and cucumber seeds, but as Dr. Nelson knows about that study that was recently done, that it didn't make a difference if you were on a seed-free diet. But some people feel more comfortable with a high-fiber diet and will have larger bowel movements, be able to pass the bowel movements easier. Diverticuli are outpouchings from the colon after many years of the colon contracting in weak points where the arteries perforate through the colon. It pops out.
Very common though, right? I mean,
very common. It's 70% of people over age 70. More common in our Western diet. Maybe we just don't have enough roughage. By report, it isn't very common in the African continent, so where their diet may be higher in fiber.
Thank you. Thank you. A caller from Duluth, another common problem, Dr. Hutchinson, irritable bowel syndrome. Can you at least mention what can we do for that?
Well, there's a long answer to that. Many long answers, probably. Irritable bowel syndrome is probably one of the most common diagnoses referred to gastroenterologists. It's very common. We used to call it purely a diagnosis of exclusion. Irritable bowel syndrome really means just recurrent abdominal pain with altered bowel habits, either chronic or recurrent constipation or chronic or recurrent diarrhea. We do want to make sure that there aren't other more serious conditions causing those symptoms like colitis, inflammatory bowel disease, colon cancer. But most often it isn't those symptoms not associated with a warning symptom like bleeding or fever or recurrent pain or night pain, rather increasing pain or night pain or weight loss. That often is irritable bowel syndrome. And we used to do a larger workup to make sure we excluded every other single cause of belly pain or constipation or diarrhea. Now we do a little bit more limited workup, but it's really important to make sure you have follow-up visits as we consider and treat irritable bowel syndrome with more minimal and logical treatments aimed at treating constipation and diarrhea, antispasmodics to diminish pain. You have to make sure you have follow-up with a gastroenterologist or primary care doc to be sure that you're on the right diagnostic track.
Thank you.
It's more of what we call a functional disease or problem rather than a pathologic issue.
So the bowel looks normal.
It is.
It's just that the way it functions and contracts is what the problem is. So it's really not a disease affecting it.
Thank you. Well, Dr. Nelson, a more serious problem here is we have a caller from Duluth wondering about a perforated colon, and maybe if you could talk about that and maybe how that might relate to diverticulitis too.
Okay. Well, perforation of the colon occurs when there's a hole in the wall of the colon. That can occur from various diseases. Colon cancer, if it grows through the wall, can cause a perforated cancer, which is a more serious condition. The most common cause of a perforated colon is the little air sac on the outside, the outpocketing, like Dr. Erickson was talking about, ruptures, and then the air and sometimes the stool leaks out and causes peritonitis in the abdomen. And if that happens, then it's an emergency situation and we have to go in and do an operation. But most diverticulitis is a little contained perforation of the colon, and they get inflammation and infection around the colon. That causes the left lower quadrant pain, fever, malaise, or not feeling well, which is the classic symptoms of diverticulitis. And those can be treated, those episodes where it's contained like that can be treated with antibiotics, usually as an outpatient. If it's more severe, then they have to come into the hospital.
Thank you. We have a caller, a couple of callers wondering about Crohn's disease and ulcerative colitis. Like, what is the difference, and are there new medications that will help treat Crohn's?
There are new medications. So ulcerative colitis is an inflammation of the lining. It's related to the colon only. Crohn's disease, briefly, is that can affect anywhere in the GI tract, and it's more of a transmural inflammation, or it can go through the wall and cause perforations and abscesses. There are new treatments. Usually we start with the usual treatments, but there are new, what we call biologic therapies out there. Every year that I go to the Crohn's and Colitis Foundation meeting, there's new biologics that are expensive, and they have to work, patients need to work with their insurance companies, often get pre-approval for those, and they have their set of side effects related to them. So we need to sit down and talk candidly with the patient. Is it worth the potential side effects and the benefits of going on the medication? And often it is. Often patients feel well on these new biologics. But your panel composition today is interesting, is that in someone with inflammatory bowel disease, the primary care is very important. And gastroenterologist works with the primary care, works with the surgeon. So a patient with inflammatory bowel disease should see this as a team approach. So it's both medical, surgical, and with the primary care.
And just a quick follow-up question. Is there a relationship between Crohn's, ulcerative colitis, and colon cancer?
There is. So the more inflammation that you have in the colon, the higher chance that the cells can mutate, and there is a higher risk of cancer. So they need to be on more regular colon cancer screening than someone that doesn't have colitis.
Thank you. Dr. Hutchinson, a caller from Duluth, would like to know about opioids, and do they cause constipation?
Opioids do cause constipation. They slow the natural motility rate of the gut, both the small intestine and the large intestine. As stool stays in the colon longer, more water can be absorbed from it, and it can become harder. When we put people on opioids, typically we should automatically think to put people also on a bowel management routine or a constipation prevention routine. Yeah, especially if they're on higher doses of opioids. That's really important.
Thank you. Dr. Nelson, a caller is wondering about rectal incontinence. Complicated subject. Just talk a little bit briefly about that and what can be done.
Sure. First of all, in order to evaluate it properly, you need to see someone who's versed in the diagnosis and the treatment of incontinence. But usually it's either of one of two things. One, it's either post-surgical or obstetrical trauma is the two most common. Then the third one would be just aging of the sphincter. Just like all your muscles as you get older get weaker, well, your anal sphincter also gets weaker. But with obstetrical trauma, the birth of the baby causes a tear and a disruption of the sphincter, and then they have problems with control. And then there's various treatments, not always surgical. A lot of times it's biofeedback, and just changing the consistency of the stool gives people a lot better control. So if they have looser liquid stools, we put them on a fiber supplement, maybe a little Imodium, and it firms up their stool and they don't have any problems with incontinence.
Thank you. Dr. Erickson, we also have a couple of callers, one from ESCO, one from Duluth, regarding colon cancer screening. I'll ask, is there an age in which you really don't need to do it anymore? And secondly, if a polyp's noted, how often do screenings have to occur?
So the first part, there's no national law that says that colon cancer screening should stop. It's a personal discussion between primary care and the gastroenterologist and the surgeon and the patient. Generally, you'd like to consider 10 years of lifespan ahead of the patients for colon cancer screening. So if someone maybe has severe emphysema or heart disease, we'll factor that in and say maybe this isn't the right test for you or could potentially be harmful. So it is a personal discussion with yourself and your providers. And the second part of the question was if the patient has a polyp. And so every polyp that we see, we don't know if that polyp is going to turn into cancer, but we do know on large studies that taking polyps out reduces the risk of colon cancer by 70 to 90%. And we do know that families then have a higher risk of colon cancer. So maybe in the future we'll know a particular gene, but we're not that accurate yet, if you would. So we're left with taking polyps out and knowing that it is reducing the mortality from colon cancer.
Thank you. And then how often after you take a polyp out, do people have it redone in 3 years, 5 years?
It depends on the
polyp.
size of the polyp and the number of the polyps. It's generally 5 years if it's 1 or 2 polyps that are small. If they're larger polyps, it can be more frequent.
Okay.
Again, a discussion to be had with the primary care.
I'd like to add to that colon cancer is the third most common cancer, and the second most common cause is cancer deaths, and they almost all start in the polyps that Dr. Erickson's describing. So it's the only cancer you can actually go in and do something to prevent it by using the colonoscopy and removing the polyp, because we call it the adenoma carcinoma sequence, or the polyp to cancer sequence. So you interrupt that by removing the polyps with the colonoscopy. So that's the importance of having your colonoscopy done.
And Tom, reflecting on your practice over the years, I mean, we're really not seeing the patients coming in with obstructing colon cancers or bleeding anymore. It's really catching in the polyp stage as you described. So it really is having an impact.
Yeah, the incidence of colon cancer is going down.
I'd read that that's the only cancer that actually is decreasing in incidence.
The beauty of colon cancer, if you can consider it having a beauty, is that it's one of those few cancers that perfectly fits all the criteria we'd want it to fit for implementing a rigorous and methodical screening program. It's almost completely preventable, and that's why I think it's such an important message to emphasize how important in general it is to think about how you're going to get screened for colon cancer and what your risk factors are, and therefore when you should start being screened for colon cancer. The lifetime risk of colon cancer in this country is 6%. That's more than 1 of 20 of us.
Interesting.
Without screening. So very important.
And one more thing to add to that, if I would again before, is that colonoscopy isn't the only colon cancer screening method. If you're concerned about colonoscopy, talk to your primary doctor. There's other methods that maybe aren't as accurate, but some screening is better than no screening.
Right.
I have Dr. Hutchinson, a question regarding, we just have about 5 minutes left. A couple of questions about colitis. It's kind of a general term that's thrown around. What is colitis? Patient say, I've got colitis.
Well, what colitis means inflammation of the colon. There are lots of forms of colitis. Inflammatory bowel disease or Crohn's disease can cause a colitis. Ulcerative colitis is another severe form of inflammatory bowel disease. It tends to be a colitis throughout the whole colon. You can have a post-infectious colitis. There can be a temporary but sometimes significant inflammation of the colon after a severe bout of diarrhea. You can have microscopic colitis or just very focal small patch areas of inflammation in the colon. It's usually diagnosed by visualization. You can have, it's a very general term, and it just means inflammation of the colon from some cause.
In the old days, people called irritable bowel syndrome spastic colitis. So a lot of the colitis that's out there, I had colitis, was actually spastic colitis, which is irritable bowel syndrome, which really isn't a colitis.
Thank you. Dr. Nelson, a caller from Floodwood, her daughter had severe abdominal pain and was told she had ischemic bowel. Is that pretty serious, and is that something that can occur again?
Yeah, that's a very serious problem. Ischemic colitis means there's not adequate blood supply to getting to the colon, and so it's deprived of adequate amount of oxygen, and so it starts to become inflamed and it can bleed. Usually it's on the basis of peripheral or arterial disease of the mesenteric arteries. Those are the arteries that bring the blood supply to the colon. And that needs to be evaluated with various studies to make sure that it's not something that can be corrected with some type of either a procedure or an operation.
Thank you. Speaking of blood vessels, caller wanting to know about colon AVMs. Dr. Erickson, what's an AVM?
Well, an AVM is almost kind of like a spider-like, it looks like a spider on the colon wall. It has kind of a central perforating vessel and it's got some extensions to it, and sometimes it can bleed in patients, so we'll go in, they're GI bleeding, we can go in and cauterize or clip those. So it is one cause of GI bleedings, and often they're there and they don't cause any bleeding.
Well, thank you. And then finally, quick question here, does caffeine cause constipation? Dr. Hutchinson.
In my mind, caffeine does not cause constipation. In most people, it stimulates bowel function or increases spasmodic activity.
That's actually the opposite.
I'd be interested
Unless
in
it-
other opinions.
Unless it dehydrates them.
Very
because
good- very good
caffeine
point.
is a diuretic.
Yeah, very good
and
point, yeah.
You get dehydrated and you get
interesting.
constipated.
Thank you.
So I always tell people that.
Thank you. Well, I'd like to thank our panelists tonight, Dr. Robert Erickson, Dr. Dave Hutchinson, and Dr. Tom Nelson, and our medical students, Maren Anderson, Danielle Lavasser, and Emily Prezek. Please join me again next week for a program on skin problems, when my panelists will be Dr. Susan Ash, Dr. Michael Beyer, and Dr. Heather Buchholz. Thank you for watching, and good night.